Hi, my name's Mervyn Singer, and I'd like to give you hopefully a little fun story about 4 centuries of intravenous fluid therapies, deja vu. And as you'll see, the arguments about what fluid, how much fluid have been raging for centuries. So my story goes back nearly 400 years, and the first blood transfusion given to man was by Denis, the physician to Louis XIV, and basically a 15-year-old boy who had so much blood taken from him by leech therapy needed a blood transfusion, and he was given sheep's blood back, and remarkably, the boy recovered. Unfortunately, Denis went on to try it on other people, and one of them was a lunatic, and the lunatic actually died, and he was tried for murder, and the church also thought this was unethical, so the practice was stopped in France. A few months later, the first case was given in the UK, in London, in front of the Royal Society. A volunteer offered to allow himself to be bled, and he too was given sheep's blood, and he too survived without problem. Let's wind forward now to 1818. The first human to human blood transfusion was performed by James Blundell. He was actually an obstetrician, but he gave his first transfusion to a man who had obstinate vomiting, made in an attempt to prolong his life. And this man was in his 30s, and he'd got pyloric stenosis, and he hadn't opened his bowels for a few weeks, and for 3 to 4 months he'd been vomiting most of his food. And he was so bad that when Dr. Blundell saw him, the guy was completely exhausted. His dissolution, his death, was expected any hour. His veins were shrunken down, his pulse was feeble, very indistinct. The vascular system had shrunk right down. So he took blood, a few ounces of blood, from a number of gentlemen present in the room, 1.5 ounces from each of them, put into a syringe and immediately infused into the vein of the patient. And he repeated this 10 times, so in total gave between 12 to 14 ounces of blood over 30 to 40 minutes. What's an ounce of blood? Well, I presume it's the same as a fluid ounce, 28 mils. So he gave in total nearly 400 mils of blood. And there wasn't any obvious change, good or bad, in terms of the brain, respiration, temperature, etc. Though he did notice that the bluish discoloration of the hands gave way to a more healthy complexion. They followed up the patient, and a few hours later, they noticed the patient was actually experiencing what they called a very salutary change, a marked improvement. His body became warmer, breathing became regular, the pulse now beat with great regularity, more strength, 88 times a minute. And when asked how he was feeling, the patient replied, "I'm better, much better, less fainty." And he said it with a much stronger voice than he'd been using before. So a great success. Blundell actually queried that perhaps giving more blood would have been unwise. So to have thrown a large quantity of blood, for example, 2 to 3 pints, that's approximately 2 liters of blood at once, may not have been such a good idea. This patient was exhausted, the heart, the blood vessels were feeble, their capacity to take all of this blood may not have been so good. And he also recognized that taking blood out clotted, and they didn't obviously know about anticoagulants there. So basically, if you take the blood out and inject it within a minute, that doesn't cause an unfavorable change. And the patient eventually died of his pyloric stenosis, but during that period, there didn't seem to be any obvious side effects from the blood. Blundell, I mentioned, was an obstetrician. So in 1825, he reported a series of cases of giving women with postpartum hemorrhage a blood transfusion. And the first one was performed 3 weeks prior. And this poor woman, 25 years of age, was having a marked postpartum hemorrhage. When visited by her normal obstetrician, her pulse was scarcely palpable. Her lips and face were of a pallid, death-like hue. And in a word, the taper of life, the candle of life, was but faintly glimmering. She was dying. And so he was called to see the patient, and he asked the husband, a robust, healthy young man, was called in, and he took blood from him and gave it to the man's wife. So he gave him 2 ounces of blood, took it into a glass cup, and then immediately with a syringe injected it into the husband's wife, the patient. He didn't see any obvious improvement, and so after a pause of a few minutes, gave another 2 ounces. So in total, 112 mils. And after a lapse of 5 to 10 minutes, the patient was evidently improving, and she carried on improving and didn't have a single bad symptom that he attributed to the blood transfusion. He did acknowledge that only 4 ounces of blood were injected, and so that may be questioned by some whether this supply of so small a quantity really saved the patient. The doctor, however, was decidedly of the opinion that this supply of vital fluid turned the scales in the patient's favor and rescued her from death. He later on described in the Lancet 10 more cases, 5 of whom benefited and survived, and he also described his device for delivering the blood quickly. So the blood went into a gravitator and then could be injected into the patient. A few years later, Dr. Latta in Scotland, near Edinburgh, described the first use of saline, and this was in patients with cholera. And as you see here, and this is often shown by people talking about saline and fluid resuscitation, he described it that he hasn't seen one bad symptom attributable to the intravenous saline, and he has no doubt that when carefully applied to be one of the most powerful and safest remedies yet used in the collapse stage of cholera. He injected into his patients up to 120 ounces, and like magic, instead of death being likely, life and vivacity were returned. In this first patient, diarrhea recurred in 3 hours. She again deteriorated. He gave a further 120 ounces, once again with good effect. And in total, 330 ounces were used in 12 hours. And basically, she got better. And in 48 hours, she was smoking her pipe, free from distemper, free from illness. And I reckon 330 ounces equates to 9.2 liters of fluid. Interestingly, a month later, he wrote back to the editor of The Lancet complaining that people had been objecting, medical practitioners had been objecting to this procedure of venous injections into cholera patients, but they'd been going to the lay press, and he felt that this was totally unprofessional and unethical. And he felt this was mainly to give them some notice in the media, or perhaps this was being spiteful. The interesting thing about Latta's work, that what people don't mention, is that a few months later, this is in October 1832, he wrote back to the editor of The Lancet, commenting that those who deemed giving intravenous saline a remedy worthy of trial for collapse in cholera have often been disappointed by the evanescent nature, the short-term nature of the good symptoms produced by it. To render these more permanent appeared to him, Dr. Latta, to be highly desirable. Beforehand, people had aimed mainly at repeating the saline, and incredible quantities have been used, and he has no doubt sometimes evil consequences have been the result. So he recognized that giving too much fluid could actually be harmful. And as you see from the title of this letter, he believed that warming the fluid or warming the patient may be beneficial. And what did he put in this warmed fluid? Artificial serum saturating water with protoxide of nitrogen, murate and subcarbonate of soda, etc. So you can see he'd moved away from saline after just 6 months or so, or less than 6 months. Let's move forward now to 1906. So essentially, blood transfusion had gone out of favor, and George Cryle, an American surgeon, one of the founders of the Cleveland Clinic, reported a series of cases where he'd given blood to the patient. And his first case was a 23-year-old man who'd had a nephrolithotomy. And by evening, the patient was bleeding, he was deteriorating, his hemoglobin was falling, he was very tachycardic, 160 beats a minute, barely palpable pulse, respirations 48 beats per minute. He was gasping, unconscious, and he tried treating it by posture, bandaging, saline infusions, stimulants, adrenaline solutions, to no avail. It was clear that the patient was dying. It seemed therefore a suitable case for trying blood transfusion, and a willing donor in the person of the patient's brother came forward. And basically, what Cryle did was he anastomosed a tube from the radial artery of the brother into the basilic vein of the patient and allowed the flow of blood to go from brother to patient over 30 minutes. And as a result, he came out of his unconscious state, heart rate fell, respiration fell, blood pressure rose, hemoglobin rose. Interestingly, they were not concentrating on the patient, on the brother, but the patient. And when they looked at the brother, he was looking rather pale and ashen and shocked because they'd taken too much blood out of him. But nevertheless, they stopped the transfusion, both recovered, and the patient was in such good condition that they could then perform more surgery. The nice end to the story, and this is more than 50 years later, the brother, the patient, and another brother who subsequently gave another blood transfusion all lived to tell the tale, and there they are showing off their scars. The following year, this was reported in the British Medical Journal in an editorial, and they mentioned that the results of his work on transfusion of blood, and he'd also done it in animal models as well, seemed likely to arouse renewed interest in a subject that for many years past had lost much of its importance. And they reported Cryle's animal studies that it raised and sustained blood pressure to a much higher degree than intravenous injection of saline solutions. And they noted that excellent results were obtained in some cases of shock. However, the editorial commented that surgeons, we imagine, will find no good reason given here for abandoning their current safe and simple method of saline injection. So even though Cryle was suggesting benefit over and above saline, the editorial said, well, just stick with what you normally do. Interestingly, that same year, another surgeon, this is a British surgeon who became Lord Moynihan. He was the president of the Royal College of Surgeons. He actually was the first to bring rubber gloves to the practice of surgery. He actually experimented with giving large amounts of fluid by the rectum. And here he reported the treatment of peritonitis. He treated 19 cases with rectal fluid and only had 2 deaths. And he believed this was all down to giving saline into the rectum over 2 to 4 days. And he gave a lot. The most he gave to a patient in the first 24 hours was 16 pints. That's about 10 liters of fluid. And the largest quantity was 29 pints. That's about 15 to 20 liters of fluid over a 3-day period. He felt these quantities were managed quite easily by the patient without any distress, and the change in appearance of the patient so rapidly is very remarkable. Let's now move the clock forward to the beginning of the 20th, or nearly the end of the 19th century. So Sidney Ringer, the father of Ringer's lactate, published his paper, but this was more of a dog model that he was looking at, and actually in vitro models too of contracting muscle. And he, as I mentioned, was a professor of medicine at University College London. About 30 odd years later, a professor of physiology at University College London, William Bayliss, who was the brother-in-law of Starling, Ernest Starling of Starling's Law fame, actually wrote this article. It was based on a lecture he'd given to the Royal College of Physicians, and the article came out in the British Medical Journal in 1918. And he was rather rude about his erstwhile colleague at University College London. He put down that Ringer's solution, although naturally one of the first to be tried, has been found to be useless, both experimentally and in actual practice. It leaves the blood in the course of 30 minutes or so, and the blood pressure returns to its former level or even lower. And he argued this was because of a low viscosity and the absence of, it wasn't a colloid with an osmotic pressure. He argued that hypertonic saline had much the same effect. He found experimentally that 2% saline solution is very little, if any, superior to isotonic saline for the purpose of shock resuscitation. He talked about addition of calcium. It acts as a vasoconstrictor, but he didn't find it gave any added benefit. And he argued that colloid was the way forward, gum arabic or gelatins. The problem with gelatins, it comes from bones, so there was a risk of it carrying tetanus spores and potentially intravascular clotting. However, gum arabic seemed to be. And he found its effect, and this was also seen during the First World War, to be most effective after hemorrhage, but it was also used in other forms of shock. During the First World War, there was also more interest in the use of blood transfusion. The use of citrate as an anticoagulant was done during World War I. He also commented on bicarbonate. Yes, there might be an acidosis found in wound shock. Hannon had reported this. However, he argued that the pH of blood represented a very tiny change in nanomolar concentrations of hydrogen ion, so he couldn't actually see the argument for using bicarbonate. Let's move forward to the Second World War. Management of wound shock, and they looked at two periods: in 1940, when London was being bombed, the Blitz, and in the front line in Italy 4 years later. And they argued that management had changed quite dramatically and for the better in that 4-year period. Early treatment was misdirected, even harmful. Avoidable illness and loss of life were the result. And they felt, most importantly, transfusion was given earlier and more freely in the later period. It became clear that patients with very large wounds, if transfusion was given too slowly and hypotension allowed to persist, death is likely to follow, even if belatedly large transfusions were given. However, if you gave them rapidly and in generous amounts, the circulation could be rapidly restored. And what did they do in the early years? Well, basically, they left the patients alone. They had them in a head down position, gave them some morphine, and warmed them with an electric cradle or with hot water bottles. And they often didn't even undress them because that was thought to upset them and make things worse. Sometimes they would give oxygen or drugs such as choramine, which is a catecholamine, or adrenaline. And transfusion was resorted to only as a last-ditch measure when all of the above things had failed. It was seldom used prophylactically. Early transfusion was regarded as dangerous because it could renew bleeding and thought to overburden the circulation, dilate the heart, cause pulmonary edema. And obviously transfusion reactions were common and feared as harmful. And they also commented on how much blood should be given. Perhaps at the beginning, they thought that just getting the blood pressure to 100 or over was satisfactory, but then they recognized that the blood pressure on its own wasn't necessarily a good marker. And they found that there wasn't a good relationship between blood pressure and the volume of blood that the patient needed. And so patients thought to be over transfused did better than others. Let's move the clock now forward to 1967, a brief mention of the first description of ARDS in the Lancet from Petty and colleagues. And you can see there on the right-hand column, fluid overload was clearly identified as being a major cause of ARDS in these 12 patients. Around the same time, studies were being done with more invasive monitoring. So Will Shoemaker, a pioneer in this area, compared crystalloid against colloid therapy, the colloid being albumin, and found the hemodynamics were much better maintained. Oxygen consumption was much better maintained if the patient got albumin rather than lactate. A few years later, though, systematic reviews came out, and these weren't very good reviews, but they lumped together old historical trial children, burn patients, perioperative patients, etc., and suggested that colloid solutions actually increased the risk of death, so by 1 in 25. And they also published that albumin was potentially harmful, increased death for a number needed to treat to cause an additional death of 17 patients. As a consequence, the use of albumin fell dramatically in the UK when these papers came out. However, they were subsequently challenged in randomized trials, and this dramatic effect wasn't noted. The Australians published the SAFE trial, and they found that the amount of albumin to the amount of saline, so generally you needed about 40% more saline than albumin, but overall there was no effect. Interestingly, there was a bit of a signal to benefit with albumin in septic patients. It wasn't quite significant, but a trend towards harm in patients with trauma, especially head trauma. So maybe you need to find the fluid to suit the situation. Frank Brunkhorst and colleagues from Germany did this trial looking at pentastarch resuscitation and found there was an outcome benefit from using lactate over a pentastarch, a starch. You can see here the mortality difference was quite marked, especially when patients were given high doses of hetastarch. But these were huge doses, and the same for renal replacement therapy. These patients were being given up to 17 liters of starch, 250 mils per kilo plus, and that's where the differences were seen. So clearly, if you drown people in huge amounts of synthetic starch, they're not going to do very well. Again, we're now more familiar with too much fluid being harmful. The ARDSNet trial showed this impaired lung injury. And I'll finish with this slide, the great fluid debate. This is nice infographic, and they looked at a variety of trials comparing balanced and unbalanced solutions. There was the SMART trial, the SALT-ED trial, a more recent trial just published perioperatively called the SOLAR trial. And basically, there was no difference in mortality or length of stay in ICU or hospital. There was a slight difference in adverse kidney events within 30 days, but we're talking 1% in absolute terms. So my summary, best fluid, best volume arguments have been raging for centuries. Plus ça change. Thank you very much indeed for listening.